All right, Dr. Fisher, let's begin. I will introduce you now because I know that there will be probably quite a bit of questions at the end, so I want to make sure we have enough time for you to be able to answer those. So welcome, everybody. My name is Susan Lautenbach. I am a volunteer here at Epilepsy Awareness Day at Disneyland, and I'm also an employee of SK Life Science. It is my honor and pleasure to be introducing Dr. Fisher, MD, PhD. Dr. Fisher is a professor and director of the Stanford Epilepsy Center and EEG Lab, and he cares for people with epilepsy in a Stanford clinic. He has published about 240 peer-reviewed articles and has written 3 books. He has been named every year from 1996 to 2021 in Best Doctors in America. Dr. Fisher received prestigious awards from the International League Against Epilepsy, American Epilepsy Society, and the American Academy of Neurology, the Kleinstein Foundation, and NIH. Dr. Fisher is past president of the American Epilepsy Society. He served as editor-in-chief of the journal Epilepsia and one of the world's most visited website about epilepsy, epilepsy.com. Dr. Fisher led the projects to develop a formal definition of who has epilepsy and an update of seizure type classification. His recent research is on new devices to detect and treat seizures, particularly with neurostimulation. And his talk today is VNS versus RNS versus DBS. Thank you so much, Dr. Fisher, for your time. And thank you, everybody, for joining us this morning or afternoon, depending where you are.
Thank you, Susan. Yes, indeed. Thank you for coming virtually. Hopefully, next year, I understand it will be live again in Disneyland. I'm going to talk to you today about neuromodulation, which I use synonymously with neurostimulation for epilepsy. And this comes in 3 flavors: vagus nerve stimulation, responsive neurostimulation, deep brain stimulation. And I'll try to answer the questions, what are these? How do they differ? Which ones work better? What are the side effects? And how would a person determine whether to use them and which one to use? That's a lot of territory, so I won't be able to go into depth on most of those questions. But if you have questions about it, just go ahead and put it in the chat, and we'll see if we can answer them in a bit more detail. I should disclose my conflicts of interest. They aren't many. I do some consulting and teaching for Medtronic. I led the trial for deep brain stimulation for epilepsy, and also the national trial of the heart rate sensing vagus nerve stimulator. Didn't get paid for those. I make no money from selling devices. I'm not trying to sell you anything today, and I'm not being paid by anyone for this talk. So why consider neuromodulation or neurostimulation? Again, the same. Epilepsy, as I think you know if you're here, is one of the most common and important neurological conditions. Affects 65 million people worldwide, about 3.5 in the US. So about just a little under 1% of the world has epilepsy. 2/3 of these people can be controlled satisfactorily with any of the 27 medicines we now have available in the US. But epilepsy is so common that the 1/3 who are not controlled is more than people with all brain tumors. It's more than all multiple sclerosis, muscular dystrophy, Guillain-Barré disease, Lou Gehrig disease, and many other diseases that the world hears a lot more about. Not a solved problem. So, what are our treatments for epilepsy? They're mostly medicines, occasionally brain surgery. Some people make use of alternative medications. There's ketogenic diet. But the big new thing in treatment the past few years has been electrical stimulation, neurostimulation for epilepsy. It's been done at many places in the brain. But these are the 3 places that have been approved by the FDA on the basis of large controlled studies. The earliest, going all the way back to 1998, was vagus nerve in the throat. And then stimulation right at the point of the seizure focus, either in cortex or perhaps hippocampus, which is the most seizure-prone part of brain, came in 2013. And then the newest one, the trial I led, stimulation of the anterior nucleus of thalamus for epilepsy, SANTE, came in 2018. So these are the three that I'll talk about. Let's do them in order that they were introduced. First, vagus nerve stimulation. The vagus nerve is a nerve in the neck. The stimulator goes in the chest, under the skin, is tunneled a wire over the collarbone, all still under the skin, and spiraled around the vagus nerve. The vagus nerve has a lot of connections. Ingoing, it of course goes to brain, which is why we use it as a way station for stimulation. Outgoing, it goes to heart, intestine, stomach, lungs, spinal cord. So we might say, what happens in Vegas doesn't stay in Vegas. Okay, that will be the only time I will do that during this talk, I think. We always do the left vagus nerve because it is the side that goes more to the brain as opposed to the organs. It carries the electricity to the brain. That desynchronizes the brainwave patterns and it inhibits seizures, even for a while after the stimulation, which is why we can get away with doing it 30 seconds on and then 5 minutes off, because doing it all of the time would make a person hoarse all of the time, and it would deplete the battery pretty fast. As it is with intermittent stimulation, the battery lasts about 5 years. So one interesting feature of all three of these neuromodulation technologies is that they don't work right away. They get better over time, over a few years. That's different, for example, from neurostimulation for tremor, where the person gets better immediately, right in the operating room. And if you want, we could talk about why there are those differences, but neuromodulation for epilepsy requires some patience. So this is a vagus nerve showing the responder rate, which are the percentage of people whose seizures are cut in half or better, and the bars go up over 2 years, this is months. And then this is the reduction in seizure frequency, and about 8% of people become seizure-free with vagus nerve stimulation for at least 6 months. So that's good for them, but it's not a very big number. Now, there are currently 3 methods to give the stimulation with VNS. The one that's most common and was tested in the trials is on for 30 seconds of every 5 minutes. And that is automatic on a clock cycle, which we can change with a programmer, but that's the usual. If a person can feel a seizure coming on, they have a magnet that the company gives them, and it can swipe across the chest and turn the stimulator on when they feel an aura or something coming on. That's addition to the cycling. And then the latest, the trial that I led, is the vagus nerve stimulator box, which sits right next to the heart and the chest, outside the rib cage though, can easily sense the EKG. And when the heart rate goes up like it does during a seizure, it can come on automatically then. In addition to these other 2 ways of turning it on still happen. So this shows an example of that. Here you have, in this part, you have brain waves, and here you have the heart rate, which speeds up from 80 to 96 beats per minute. That's detected by the device. It gives a stimulation, and these seizure waves here stop with the stimulation. So that's now approved, and this is the device that most of us would put in if we were to give you vagus nerve stimulator. Is it better to have that heart rate sensing feature? The answer is probably. Here are 2 studies that say it's better. In this first one, you see a bar without the heart rate sensing, and then here you put the heart rate sensing in, and you can see, for example, the no seizures in green goes from 5 to 8%, the 80 to 99% improvement, 16 to 27%, and so on. And it just shifts towards better response. And here you also see curves going up in another study in patients who had the heart rate sensor device put in, and many of them improved when they leveled out or didn't benefit before. So I think it's a better way of doing it. So here's the summary. During the pivotal trial, which was double-blinded, meaning there was a placebo-controlled group, there was a definite but modest improvement with a 31% reduction in seizures versus 11% in the placebo group. Long-term, remember I said it improves over time. That builds up to about 52% reduction in seizures. Most of the problems are in the neck discomfort or pain, a hoarse voice, people talk like the Godfather when the stimulator comes on. But these things get better over a few months as we slowly turn up the current. And most of the time after it's been in for a few months, people don't mind it at all. Although I can always tell when someone's vagus nerve stimulator comes on because of a change in the way they sound. Probably would not want to use it in an opera singer. Now I'm talking about side effects, but VNS has a beneficial side effect in that it seems to help depression. And this is great because people with uncontrolled seizures have a lot of depression. This chart, I won't go into in great detail, but the medium and the high stimulation bars, which are the shaded in ones, are better in terms of getting rid of depression than the open bars, which is the lowest level of stimulation. So vagus nerve stimulation is an approved treatment for depression as well as seizures. And so I would think it would be particularly good in patients who had both. Let's move on now to number 2 stimulation type, which is the responsive neurostimulation called RNS. This is a marvel of engineering. It's a little EEG machine that gets implanted in the skull. And let me just make an aside for a moment because people have this image. What does it mean, implanted in the skull? Well, actually, the surgeon will put a metal brain pan in the skull, and that presumably stays there lifelong. So when the vagus nerve stimulator battery needs to be changed, which could be every 5 to 10 years or so, depending on the settings, you just have to cut the skin, take the stimulator out, put a new one in, and plug in the brain leads, which stay the same. So you don't actually have to go back to the brain anymore when it's replaced. So as you can see, the machine has 2 wires, and for the device to work, you have to put it over the seizure focus. It can either be a flat strip with 4 contacts, or it can be a wire with 4 wraparound contacts at the tip. But one consequence is we need to know where the seizures are coming from, and there can't be more than 2 in order to use the responsive neurostimulator. So once the stimulator is in, it is continuously recording EEG, and when it detects a seizure, it will stimulate to try to counteract the seizure. Here's how that looks, and this shows a real skull X-ray with a VNS in place and some of the electrodes over the seizure area. A seizure starts, and if you don't give any stimulation, it just goes on for about a minute, up to 60 seconds. But in the next seizure, if you turn the stimulator on, you can see how the seizure is much shorter. This doesn't always work, but it shortens a number of the seizures and probably also has some role in preventing seizures too. This was the pivotal trial, which means the trial that made the FDA approve the device. And you can see that with placebo, the dotted line, the seizure count per month is higher than with the RNS treatment. Down is fewer seizures. So this was statistically significant. If we continue that over the long term, you can see, as I said, that the seizures keep going down for 1 year, 2 years, really up to 5 years or so. But it's important, if you have these devices in, you have to be a little bit patient. You may get about a 30 or 40% improvement after 3 months. But in order to get the bigger improvement, like 70%, got to wait a couple of years. And not everyone gets it. So, of course, what everybody wants is to be seizure-free. How often does that happen? Well, these devices, unlike some surgeries, are not typically curative. They just improve, reduce the number and often intensity of the seizures. But some people do become seizure-free with the device. And if you consider that in the clinical trials, the people who were implanted were having about 15 to 20 seizures per month. This is how many of them would be seizure-free for 6 months or longer. With the RNS, about 18% were seizure-free for over 2 years, and 23% were seizure-free for at least 6 months. So that's not too shabby. And this is the summary then on RNS, that the effectiveness in the controlled blinded study was 38% versus 9%. Long-term, about a 66% reduction. And the main negative side effects, basically, if you didn't get into trouble right around the time the thing was implanted, there really weren't many side effects. A few people had some more seizures, but I'm not sure that was the fault of the device. It may just have meant that the device wasn't working. Now, there's a special benefit of VNS that the other two don't have, and that's the ability to serve as an automatic seizure diary, because it's always recording the EEG, and it detects a lot of things that it will register to and stimulate. But if you consider the long detections, the seizure-like events that go on a minute or 2 minutes, they tend to be pretty good markers for when someone is going to have a clinical seizure where we'll have confusion, memory problems, or maybe even a tonic-clonic with stiffening and jerking. So you can correlate the report of how many seizures people have if they keep a seizure diary, a log, with how many of these long detections you have in your responsive neurostimulator. And the answer is that the long detections pick up almost all of the seizures. So the pluses are seizures that patients record, and the RNS the black circles are detected by the RNS device. And although patients, were reporting more seizures, I can tell you that the big ones are almost always picked up. These are the overlaps of the plus and the circle with both. Another advantage is the device can tell you when we assay it with a programmer outside the skin, whether the seizures come from the left side or the right side. So there have been some patients where we put RNS with one lead in the left hippocampus, the most seizure-prone structure of brain, and the other lead in the right hippocampus, because it looked like seizures were coming from both. But a year later, when you look at the record from the stimulator, you might say, oh, look, 90% of them are coming from the right hippocampus. So let's go back and laser that hippocampus out and see, take the RNS out and see if we can cure them with surgery. So it's a good seizure detector as well. All right, let's go to number 3 now, deep brain stimulation. Deep brain stimulation puts wires not into the seizure focus, but into what we now call the network. The network is the big buzzword in epilepsy this decade, because we don't think seizures involve just one hotspot. There is a place that they start. If we can remove that with surgery, then we can maybe cure or almost cure the patient. But another approach is to stimulate somewhere along the network where the seizures spread and start recruiting the rest of the brain into the seizure. And that's what this is doing. We implant stimulator in the chest, not in the skull, but like the vagus nerve, and run a wire both on one side of the neck, but then we will put it into the left and the right thalamus with 4 contacts at the tip on each side, like you see here. So the thalamus is a pacemaker area for a lot of the brain. And the anterior part of the thalamus, ANT, anterior nucleus of thalamus, affects the frontal lobe, which is grayed in here, and the temporal lobe. And those are the 2 lobes that are most involved in most adults who have seizures. So it gives us some control even when we don't know exactly where the seizures are coming from or what the network involved is. Chances are, if you stimulate the anterior nucleus of thalamus, you'll be getting some stimulation into the territory. This is the result of the pivotal trial of the deep brain stimulator, the trial that I ran for Medtronic, published quite a long time ago, actually. So we put the stimulator in, and by the way, in all of these trials, when you do a surgical procedure, people seem to get ready, get better right away to the tune of about 20%, even before we turn the stimulator on, which happens at this dotted line. And there have been a lot of potential explanations for that. Why do you get better just from doing the procedure? Probably the simplest explanation is that people don't go into a surgical trial when they're doing well. So they wait until they're doing badly. And just by chance then, if they're at a low point, the next measurement will be better. However, at this point, we go into the controlled phase, where in the dotted line, we've got placebo control with no stimulation on. The patients can't feel the stimulation, so they really don't know. And in the green solid line, we have a 5-volt stimulation turned on, not for 30 seconds, but we did it for a whole minute, 1 minute on and 5 minutes off. Again, not continuous because we wanted to preserve battery life. And the result is that the patients who had the stimulation ended up with a 40% reduction after 3 months versus a 14.5% reduction in the placebo group. And that was statistically significant. Now, here's what made me believe that it really was doing something. When the patients in the placebo group had the stimulator turned on, and they didn't know they were in the placebo group until the study was over, they immediately started improving down to the level of the patients who'd been stimulated all along and kept improving over time. People injure themselves during seizures. I don't need to tell some of you about that. So I was pleased to see that deep brain stimulation, even in the blinded phase, reduced the injuries due to seizures. The falls, the broken bones, the chipped teeth, the bruises. And I think the reason for this is because part of what DBS is doing as it stimulates the network is it keeps the seizure from spreading to lots of other parts of the brain that might make you shake, might make you fall down. And so injuries are less. Here's the long-term control of the deep brain stimulator. And it shows that by the time you get out to 7 years, you're more than 2/3 reduction. In fact, by the time you get out to 5 years, you're 2/3 reduction of total seizures from the baseline. And by the way, this has a statistical method for accounting for dropouts. You have to do that, or over time, you're only measuring the results in the patients who are left who did well. But this chart accounts for dropouts. And we had about 18% who were seizure-free for 6 months or longer. Remember, starting with average of 20 seizures per month. 8% seizure-free for at least 2 years, 9% for the 6 months prior to the last year. Here's the summary then on DBS. In the blinded phase, there was a 40% reduction. In the long term, about a 70% reduction. And the main side effects are you feel tingling sometimes in the chest because the stimulator is part of the circuit. That goes away if you turn the stimulator down. But the 2 things that we were mostly concerned about, and I see that I have left one of those off the slide. I'll fix it for next time, are temporary impairment in memory and in mood, meaning increased depression. You know, it wasn't major, but there were more people who complained of memory or mood problems in the 5-volt stimulated group than in the placebo group. That responded when we turned the stimulation down, and when we looked at them a few years later, it was no longer there. Although by then, if they'd improved, we'd probably cut their medicines down, and that also would help those things. But I don't like putting a DBS in someone who's seriously depressed, mild depression. Probably better. Then here's the long-term effectiveness, VNS, RNS, DBS. And DBS is at the top, but I don't know that it's statistically significantly different. And then the side effects we talked about for the vagus nerve, it's mostly throat and voice change issues. The RNS, you may get infections when you implant in the skull, some sight pain. A few people have more seizures. A big thing is finding that it's not working because you didn't exactly know where the seizure focus was, and you didn't put the 2 wires in the right place. DBS also has some infections at the site, no brain infections in the trial, tingling at the stimulator, transient depression and memory problems. And at high, if the voltage is too high, people can have a few seizures triggered by the stimulation. And again, that responds by turning the stimulation down. So that's a comparison between the 3. Let me make just mention in one slide that some of us, including me, are working hard to find a way to deliver neurostimulation without having to put holes in the head with non-invasive testing. And this we do with magnetic or battery direct current stimulation to patches that we just put on the head, wet saline patches or sponges. And some of those studies are showing that there's benefit from those. I am doing a study of home transcranial direct current stimulation, and hopefully we'll be able to get some benefit from that without having to do anything invasive. So how would you choose since these 3 are available? Well, the first thing that we have to do is we have to determine the type of epilepsy, because these are approved for focal seizures, seizures that start in one place in the brain. Generalized seizures, what used to be called the old petit mal or grand mal, are not quite as proven for stimulation, although the deep brain stimulator in a different nucleus of thalamus called centromedian has several articles showing that it helps generalized seizures, like in kids with a Lennox-Gastaut syndrome. But it's not FDA approved for that yet. Then determine if the seizures are intractable, meaning not responsive to medications, which, remember I said happens in about a third of people. Determine if the seizures all come from one identifiable place and that place is safe to remove surgically, because then surgery, or even better, laser surgery, which can send you home the next day, might be a better treatment than neurostimulation, which is usually not curative. But if you have intractable seizures not responding to meds and you don't have a removable seizure focus, then consider neuromodulation. If a person doesn't want us to do anything with their head, keep away from my head, then it's got to be vagus nerve stimulation. Although if they don't like the idea of it bothering the voice, then it's not vagus nerve stimulation. If it needs seizure recording, then RNS is a good seizure diary, as well as a pretty effective treatment, providing you know where the seizures come from. If it's unclear where the seizures come from, or we're going to have to do, big studies, bothersome studies, maybe put wires in the head just to measure where seizures come from, then it might be better to do DBS or VNS, because they don't require that we know precisely where the seizures come from. And VNS has an added benefit if a person's also depressed, then that can benefit too. So these are kind of how I decide with my patients and my team which one of these to use, but these are all pretty new, so we'll learn some more as we go.
Dr. Fisher,
yes.
Before you move on, sorry to interrupt you. There was a question about, are any of these used in children, any of these devices?
Yes, vagus nerve stimulation can go down to age 2. DBS and RNS are approved for age 16 to 18, but we doctors do things that are off-label or unapproved all the time. In fact, most drug use in pediatric epilepsy is unapproved. The question is, will the insurance companies pay for it if it's unapproved? And that's figured out on a case-by-case basis. But all three of these work in children. So I come to my last slide, which are these points. Neuromodulation is in its infancy, but it's already having a big impact. You know, I've been doing this for over 30 years, and so I've been to a lot of weekly seizure surgery conferences. I can tell you that for the first 2 decades of doing this, an awful lot of the time, we'd end up saying, cannot help this person. We can't really identify a clear surgical site, or it's not safe to take out. The medicines don't work. Let's just wait for something better. Now it is quite rare. It still happens, but it's quite rare for us to say we can't do anything. Because usually if we can't remove a seizure focus, then we can do something with neurostimulation to at least try to improve the situation. VNS, RNS, and DBS have similar effectiveness against the seizures. There are more people who are seizure-free with RNS or DBS, but VNS is, safer, I think, because it doesn't involve any surgical procedure on the brain. May irritate the voice or the throat. RNS has a good safety profile, but requires localizing the seizure focus, which we can't always do. RNS can record seizures. DBS does not require localization. DBS may cause usually transient memory or mood side effects. There's no accepted flowchart for choosing which to use. We consider individual factors. The main point is not to just go on having seizures and think nothing can be done, but to try some form of neuromodulation. Choose wisely, but most of all, choose. Attributed to me, trying to emulate Yoda in Star Wars. So that's all I have, and I will be happy to take any other questions that may have arisen.
Thank you, Dr. Fisher, so much. Yes, if you have a question, please use the chat or come off mute, and Dr. Fisher will answer the question, hopefully. So thank you, Dr. Fisher, for your time this morning. Any questions? I'm monitoring the chat.
You can ask me about anything. It doesn't have to be about neurostimulation.
Yeah, with your background and accomplishments, you've got a lot to share. So thank you for that. Any questions for Dr. Fisher? All right, here we go, Dr. Fisher. There's the first one. Did you see that?
Okay.
Oh, so go ahead.
Yeah, I did. Daughter had surgery 2 years. again, and continues to have seizures, any of them better after surgery? Anyone want to ask that question verbally or explain? What do you mean, any of them better after surgery?
It looks like Diana on an
Yeah, I'm
iPhone
sorry.
has
I
a
was
question.
I was
That's okay.
trying to rush. I was trying to rush. So my daughter 2 years ago did have resection surgery, and it didn't work. So are any of the stimulation, the DBS or VNS or RNS would be better after a surgery, after a resection? Like, are any of them better? Or would you have to go back and do a VEEG to see really what's best now at this point, since the surgery did not work?
Yeah, no, very good question. The first thing, although it wasn't part of your question, is for me to say that all of these neurostimulation treatments still work even after surgery didn't work. So it's not like, oh, if it didn't respond to surgery, it's not going to respond to DBS, RNS, or VNS. It still has a reasonably good chance that those will help. And similarly, if, let's say, someone had a VNS in place and it didn't help them, it may still be that RNS or DBS could help. But the second part of your question, I think you're already kind of aware of the answer, which is that it would be useful to go back and have another video EEG on the scalp to figure out why the resective surgery, resective means cutting out or lasering out, why the resective surgery didn't work. Is it because there were neighborhood seizures in the area of what was done, or are there seizures on the other side? Because that may tell you where the residual seizure focus is, and it could be then a good target for RNS. Or if couldn't find where the seizures are coming from with a video EEG, then consideration of VNS if it hasn't been tried already, or DBS would be the way I think to go.
Just to follow up, do all, like, she goes to UCSF in San Francisco, are they performing DBS, or do all the hospitals now perform the DBS? Because they're still talking about RNS first and VNS, not DBS. So
yeah, so not all hospitals, but I think all level 4 epilepsy centers, and UCSF and Stanford are both those, have the capability of performing all three different types of neurostimulation, but they have different levels of experience and comfort with each of them. And I can't speak for RNS, but I know I can't speak for UCSF, but I know they have a lot of experience with RNS and have published a lot of papers on it. So that may be what they're most comfortable with and familiar with. You know, at Stanford, I think I'm not bragging too much to say that we're the neurostimulation for epilepsy center of the world, because there are 3 pivotal FDA-approved trials, and all 3 of them were led by Stanford people. So we're comfortable with all of the modalities.
one more question, I'm sorry. She's 18. Do you think, like, pediatric versus adult, she can go either way at this point? Is it more, would it be more beneficial to go to the adult side because it's probably performed more in the adult side?
I think experience is greater on the adult side, and I think she's probably likely to become more adult as time goes on. So might be a good time to talk about transitions. But I can tell you, some pediatricians don't let go of their patients. We'll keep them until they're 60.
Thank you.
We have another question, Dr. Fisher. Both of my children have epilepsy, both completely different in presentation, and they both have the same genetic variant. We're seeing a geneticist next week, but have you seen that in your office where one has focal epilepsies and one has generalized in the same family?
Yeah, it's mystifying, isn't it? But it's well known in epilepsy that makes her life and the geneticist's life harder, but it's common that two kids can have the same gene defect, but they end up presenting as different types of epilepsy. And that just tells us that genes give you your tendency, but the tendency interacts with things going on in your world, and that has effects on your brain, can change brain wiring, can change brain's chemistry. So the gene may show up in different ways in different people. It's called genotype and phenotype. The genotype is what type of gene you have. The phenotype is how it actually shows up in a disease condition.
Hi, Doc. I had a
Hello.
question. Yolanda, my wife has epilepsy. She's had it for 25 years or so. And 7 years in, she got the VNS, and we didn't think it was working at all. She went in for an MRI. They told her she had to turn it off, and we had to rush back in to get it turned back on because her seizures just jumped to, from moderate to severe. And so we put that back on. She ended up getting the temporal lobe resection. And what the question is, and then she still had seizures after that. And then after that, we actually went to a neurology conference, and they said that she needed to maybe try different medications again, go back and try them again. That was the doctor's suggestion. And so she did, and we ended up trying Briviac, and lo and behold, after 20 years, she's seizure-free for the first time in history, And so she's gone 3 years now without a seizure. And so we don't really want to mess with anything, we just kind of want to not rock the cart. But she's curious to know if what's really doing the work, the heavy lifting. Is it the VNS? Is it the medicine? Was it the surgery? What was the
Well,
thing?
my neurologist told me that the reason my seizures actually stopped is because my new medication, Briviac. Because after I had brain surgery.
Uh-oh, did I lose you?
Yeah, there they are.
Yeah. Okay. Yeah, I was still having them after brain surgery, and they said it was coming from both of my temporal lobes.
Yeah.
So I was going to have brain surgery again, but then the doctor said, try a new medication. And believe me, they will get better. Because I went from 178 seizures in 1 year to no seizures now, thank God.
Wow.
And her epilepsy, her seizures are all tonic-clonics.
Oh, boy.
So it's
Big
it's a
deal.
huge change,
Yeah.
Yeah, it's like my friend, since I had brain surgery, she was too scared to have the big brain surgery, but she got the RNS in, and it's not stopping her seizures. She has focal seizures. Because I'm a part of Epilepsy Foundation. I literally know a lot of people with epilepsy.
So let him answer your question. What do you think?
I go by timing. If the seizure stopped when you started Briviac and they didn't stop with the VNS or the surgery, I think it was the medicine that stopped them.
Yeah, that's what my
Stop the seizure.
neurologist specialist say.
Yeah.
I'm on Briviac and Trilepta.
Yeah. So, for those who don't know, Briviac, brivaracetam, is a lot like Keppra, but it doesn't have quite as many of the irritability and mood side effects. So, that's great. Most of the time, your story is a happy story, but it's not a typical story. And here's why it's not typical. It's not typical because most people with epilepsy, if they don't respond to the first 2 or 3 medications, if the seizures don't get better, usually none of the other medications stop their seizures most of the time.
Yeah, I was on 3 different ones at one time.
The newer medicines are better in some cases. Cenobamate seems to be very powerful medicine. A new drug that hasn't come out yet by Xenon looks like it may be pretty powerful against seizures. But most of the time, if you strike out with the first 2 or 3 medicines, or I should say the medicines strike out with you, because it's not your fault if they don't work, then generally the other medicines may make you a little better, may have fewer side effects, but they don't stop the seizures. But your case is different. Riviac stopped your seizures, so you were the lucky.
Yeah, and I got the
exception.
new VNS in too.
Yeah, the
her
heart
V-
sensing VNS. Well, good. I helped develop that, but
Just
that's
one
not
last.
a that's not a
Go ahead.
cure, but it helps.
Yes.
Yeah, one last thing. Her VNS, she wasn't able to tolerate it on a higher setting because it caused her the irritation in her throat.
Yes.
So
yes.
she kept it on the lowest setting possible. It's like only, I don't know what the lowest setting is, but it's very, very low.
0.25 milliamps is the lower setting.
That's it. That's
And
it.
We
It's
like to
very,
get
very
people up to
low.
we like to get people up to 1.5.
So
Yeah.
hers has been lowest.
So
And it's still
one suggestion to make for your whatever doctor is handling your VNS, you probably know about it, but they may not have done it, is to consider reducing something called the pulse width, so that the strength is the same, but the pulses are shorter each time. Pulse
Actually, the
width.
people that made it came out and did my. Who was the people
Yeah,
that made the VNS?
Villanova sent a technician out to her doctor. We reached
Yeah.
out to them.
Yeah.
They sent somebody and they did some special settings on it. So
Okay, well,
I can't tell
they
you.
probably did that.
Yeah.
All right, let's. I'm glad you're doing well. Let's move on. Any
Thank
other
you.
questions? We probably don't have too much more time.
One or two more questions as we're coming up to the top of the hour. Anybody have a question for Dr. Fisher before we wrap it up for today? At least on this topic, not for today. 'cause we still have a couple more talks.
This is Diana again. I have one question, piggybacking on what happened to the person that had the VNS. So if you put the VNS in, and she's tried a medicine previously, with the VNS, now that it's stimulating, whatever, can you go back and try previous medicines and maybe become seizure-free?
I've done
Does
that
that-
sometimes, even without a VNS. You know, when our back's to the wall and nothing else has worked, I go through the list of medications that supposedly didn't work before. I look hard, maybe they weren't used in a good dose or for very long, or maybe they had a side effect that was part of a drug interaction with another medicine. And I will, or maybe just the brain has changed in the time, and I will try it again. It's also the case that if you have a VNS that helps a little, if you had epilepsy surgery that helps a little, both of those are not enough, but they still could maybe add some benefit to the benefit of a medication. So sure, it's sometimes worth trying the medicine again.
And one more question, Dr. Fisher, and then we'll wrap it up. For DBS placements, I heard the placement is key, so it is better to implant DBS with ROSA.
ROSA is a robot. All of the electrodes that we're putting in, whether for recording or for long-term stimulation, at Stanford, we're currently using the robot, and the positioning of it, of course, is by the surgeon who's right there next to the robot. The positioning is controlled right on the patient's MRI. Here's the entry point. Here's the target for the lead. Here's the X-ray that shows that there are no big blood vessels in the way of the implant. And once you tell the robot that, it just goes zzz, right, and puts the electrode in precisely the correct place. And it's much faster, so it's much less anesthesia time for the patient. So that is kind of a technical point, but I think ROSA is a better way to do it. There are other, by the way, robot surgeons besides that particular brand. All right. Well, thank you.
Thank you very
coming.
much, Dr. Fisher,
Elaine,
for your
and for listening.
presentation, for all to jump on and the wonderful questions. Have a wonderful day, everybody. Thank you very much.
You too.